Thanks for the opportunity to segue into Sprout. Just a little tidbit on the bribing of the gods. That did happen, but then we repented, joined the Billy Graham crusade, and then got sponsored to come to the U.S. So, that's why I'm here. So at the ATA 2015, I think it was after your talk, David, Allison Kerfman and I and Dave chat afterwards, and we thought, well, wouldn't it be great if there was a way to evaluate the impact of these guidelines and the things that we do on patient outcomes? And it wouldn't it be great if we can take advantage of collaboratives to do that? So we decided that, well, you know, children are just not smaller adults, and babies are not smaller children. So the pediatric population is different, and enough so that we should be able to formulate research projects that are directly impacting pediatrics and making it that unique. So hence the birth of Sprout, which stands for Standardized Pediatric Research on Outcomes and Utilization of Telehealth. And in a sense, it's a pediatric research collaborative aimed at doing research. So, and we realized that research and outcomes is really, really important. And if we think that the field of telehealth in itself has a wide variety of practice, pediatrics probably even more so, because now we also have the consumers. They're not just the patients, but it's also the parents. So what you see the map on the right side is the red dots is where we have members across the nation. And we have 76 institutions up to today that have signed up with Sprout, over 31 states and 3 countries, one in Germany and one in Australia. So we're really, really happy and lucky to have all this input and all this expertise. So what is our vision? We really wanted to make sure that children receive the best healthcare anywhere, anytime. So you notice there's not a word of telehealth, telemedicine in this. And this is really, really important because I think in the beginning, as we decided what the focus would be, we really wanted to be about care. It's not about the tool, it's really about the care. And that's why we came up with that vision. And then from an objective standpoint, we came up with 3. We really needed to, first of all, establish a network of collaborative research, and I can talk about that sort of prompted our first project. But also we wanted to determine the impact of telehealth on quality as well as identify best practice for implementation. So I come from a world of quality improvement. That's sort of where I come from. So implementation science is important to me, but also what's also really important is doing really groundwork clinical trials that I think will speak to the efficacy of telehealth, while implementation science speaks to the efficiency and the effectiveness of telehealth. So this is sort of the organizational or the structural model of Sprout. What we have established is research interest groups. When we sent out our first survey, it came up to about 30 to 31 clinical programs, different types of clinical programs, and then about 11 pediatric services. An example of a clinical program is dermatology, critical care. Example of a pediatric service is like audiology, occupational therapy. So we were hoping that with this network, there would be sort of an organic bubbling formation of collaboratives around these programs and clinical services. And then from those would be sort of the birth of projects. So our upcoming projects, which I'll briefly just kind of label later, are 3. And then underneath this, so why Sprout? The value of Sprout is really to facilitate and provide the operational infrastructure, at least for now, for some of these projects, which would involve establishing this network and involve the data management and local expertise, the education, and the liaisons to other organizations like the ATA, the AAP, and other organizations. And we thought that, well, there really is going to be 3 buckets of studies that we would try to facilitate. One is your traditional descriptive study, which is our first survey was actually a descriptive study. The second is multi-center trials, which again, to look at efficacy. And the third one is implementation science. as we all know, the line between what's QI and what's research is blurred oftentimes, and this actually affects our IRBs and some of that earlier discussion that we had. I'd put forth the idea that maybe there shouldn't be a line because it's a continuum. The notion that we'll use the discovery of knowledge as sort of the dividing line is probably not a good one because we're discovering knowledge with implementation science as well. What we've decided to do to define implementation science a little bit better is that if we have evidence or if we have literature to support a certain kind of practice that is fairly strong, or if we're trying to improve operations that already exist, then we're going to kind of put it in the label of implementation science. And with IRB, in the terms of IRB, try to get it through as a quality improvement effort. So our first project was important. We felt that it has to be engaging, and it really has to help us establish this network. So our goal was really to establish a database where we can actually, if somebody came up to us and said, Steve came up and said, look, I want to do a school-based health project, or I want to do a critical care project. Well, here are the people that have established programs in critical care, and these are the contacts, and this is how we can begin to gather the group. So the other thing we wanted to do in our first project is to not only assess a survey of programs, but what is their infrastructure? What is their system? You heard Curtis earlier talk about the importance of building telehealth in the context of a system. So the people, process, and tools is sort of the simplistic way I like to think of systems. So we asked in this survey questions about their people, their human resources, the processes that they have that is formal processes for telehealth, as well as the tools. And then lastly, we want to facilitate these multi-center studies. So we send out 76 invitations in various ways. And we had 57 respondents. We have 53 completed data. And what you see on the map is in white the places where we got respondents from, different states. And the kind of questions we asked demographics. So an example of a demographic question would be, do you exist at a pediatric standalone hospital, or are you part of an adult program? Some of these drivers that can either help you succeed or not succeed. We also asked about pediatric telehealth clinical service lines. And we asked whether they were established programs, piloted program, did they not have any, or they just did not know if they had any. And then we talked about infrastructure, technical resources. We also talked about funding, asked about fundings. Where do you get most of your fundings? And to our surprise, when we looked at the data, there was actually quite a bit that was, the source of funding was really from billing and from reimbursement, so which is good. And then we talked about barriers. If you did not have telehealth, what were the barriers? Was it a showstopper type of barrier, or was it not? And so we're still organizing and looking at the data. We'll be presenting the data at the ATA and the PAS upcoming. And our main goal is really to make this data disseminated as soon as we can, but also have a mechanism by which we can update this data. Because as I think in 6 months from now, that data is probably going to change at the rate of how telehealth is growing. We're looking at a way to create a data use agreement process for querying the data, and this is true for this, but not, and also future projects. What we hope to do in Sprout, I think one of our main goals is to establish a data warehouse for not only the type of telehealth programs that are around, but also the infrastructure for a data warehouse whereby future projects can also house the data. The advantage of having data in the same place from different projects is that you can begin now to talk apples to apples. You can do, it's much easier to do data validation and to make sure data definitions and data dictionaries are alike. And one of the hopes in the last 2 days being here, it was to see how we can collaborate with search. It would be wonderful if we can maybe even share the same data warehouse for all of these things that we do. Standardizing, we have established a standardized for proposal submission. We came up with a form, a very simple form. If you had an idea, please fill this form out. If you have an actual proposal, please fill this out. And so we're going to do that. Growth strategy, and then new projects. So For phase 2 projects for 2017, we have identified 3 projects. One is the NICU handoffs. This is a tele-sign-out project where we are going to do tele-sign-outs with the primary care physician of complex NICU patients that are discharged from the NICU. We have a pilot project that we've just completed at CHOP looking at that, and we want to try to learn from that and spread. And we have 2 or 3 hospital systems who are interested, one of which is Colorado, which is co-investigating this with us as well. We also want to look at it from a descriptive study standpoint, a deep dive into pediatric critical care telehealth, and Dave is helping us with that. And getting really to the 5 whys, it's the 5 W's of why, when, where, how of pediatric telehealth. And then we want to do a multi-center trial, and this is very early stage, and this is sort of an offshoot of what Steve North is doing with school-based health and looking at the value of school-based telemedicine. So lots of work ahead of us, very, very exciting, and we just want to thank you for the opportunity to share with you our experience so far.